Good afternoon, everybody. Thank you for your patience. Apologies for being a couple minutes late. Just had to juggle traffic. Rukia, if you can bring the slides up for today, please. Thanks, Rukia. And if you can make it full screen.
Sorry, I don't know why.
Hey, Rukia, we just lost the slides. We can see your screen now, Rukia. Thank you. Can't hear you, but no worries. Yeah, perfect. So thank you everybody for joining us. Happy New Year. It's feels like forever since our last meeting, and you know, obviously a lot has occurred in just not even 4 weeks, 3 weeks since we closed out 2021. But happy to have you guys here. Here's our overview of what we're going to go over for our new participants. We always start with the international flavor, and we focus more on Japan, South Korea, and then and India of some sorts because they're a big presence in the Indo-Pacific. And then we go through a national overview, focusing on the major states that have a lot of traffic to and from Hawaii, and then a state level review, and then our Hawaii overview. And typically we do science highlights because we like to give a broad perspective, not just the modeling itself, but other epidemiology and clinical and mask wearing, et cetera. But today, because we have an update from Monique and her team for model, we're gonna switch things up a bit, but we'll get started. Next slide, please, Rukia. Perfect. So with Japan, you know, similar to what we're seeing in most countries across the world, seeing an impact due to Omicron. So, you know, the previous wave was Delta. You know, now it's firmly Omicron. They are earlier in their stage of infectivity and spread of disease than United States and Hawaii. So because of we have a lot of travel from Japan to Hawaii, we definitely keep an eye on that, given that we still have our Safe Travels program. Next slide. South Korea, on the other hand, is trending down. They also have some mitigations in place. They have kept the 10-day quarantine versus an isolation quarantine versus what CDC changed to 5 days from 10 days that we had. I think they changed it last week. But once again, it remains to be seen if they're going to continue this downward trend or tick back upwards. You know, from the last couple of days, it seems to rise. But you know, we need to, you know, 1 or 2 days a trend does not make. So we will continue to keep a close eye on South Korea. Next slide. You know, India, obviously, they were the first major country to experience Delta, and you know, people thought, you know, with such a big population that experienced, you know, natural immunity, it came at a huge cost, death toll, hospitalizations, et cetera. You know, over 6 months have passed. You know, we're seeing an uptick in their Omicron cases. So once again, a big partner in the Indo-Pacific region, and so we're continuing to keep a close eye on them as well. Next slide. So as you can tell by the dark red color of our country, definitely not trending in the correct direction. You look at our trends, from the past 18, 20 months, obviously the highest we've ever been, speaks to the tremendous infectivity of Omicron as compared to Delta and the original strain. But also the number of tests, hospitalizations, and deaths have also increased. Next slide. Not much to say here except Arizona and California mirror the national trends in the significantly sharp increase in cases. And to the point of hospitalizations, they also, both states have also seen an increase as well. Next slide. Nevada, Texas, similar trends here. Don't have quite as much fidelity on their day-to-day because we're focused on Hawaii, but once again, we do look to these 4 states because there is a lot of travel both from our residents to and from these states, and also we get a lot of tourism from those 4 states as well. Next slide. So for our state overview, cases per 100,000 and positivity rate both need to be looked at together. You can't look at one without the other. If you just look at cases, once again, it doesn't provide a lot of context, which is why we also look at the testing percent positivity. Unfortunately, both metrics are definitely higher than they ever were and higher than we would like to see. So those are 2 of our leading indicators that I'll speak to towards the end of the presentation. Next slide, please. So in terms of our vaccine administration, Hawaii continues to be in the top 5 or 10 states across the country in terms of vaccinations, including boosters. And we do know from the science that even just 2 doses of the mRNA still offers significant protection against severe illness, though decreased protection against infection due to Omicron. Next slide, please. So moving on to our HiPAM forecast on our website, which differs slightly from our weekly report. Once again, for everybody who's new to HiPAM, this gets updated a little more frequently, but has a little less granularity in terms of some of the assumptions that we have. But we think it offers value because it is a little more real time than our weekly releases that we've come to release to the public during Omicron. But obviously, for cases and in hospitalizations, it's no surprise that we're continuing to trend upwards and projecting upwards as well. Deaths, once again, continue to be, and I'll speak to this again, the limitations with deaths because of the data and some of the nuances with the data that we get from the state and the releases for death. But that's our forecast from our website itself. And we have Dr. Shiba, who's going to speak more later on this afternoon on our other modeling. Next slide, please, Rukia. Finally, this is just, if you're more of a numbers person, this is just what you saw in the previous slide, but just in a numerical format. And once again, want to be very clear, this model is a little different than what we are going to present in a few minutes. Next slide. So before we go into what I'm sure everybody is hoping to gather is, when are we gonna peak? What is the peak gonna look like? How many cases, how many hospitalizations? We'll speak to that definitely, and definitely wanna let Dr. Shiba speak to that. But I think close to 2 years in, as a professor, as an educator, I always like to go back to basics. And the next couple of slides is just to level the bubble with everybody here, regardless if you're a novice or you're a seasoned armchair epidemiologist. Just want to go back to basics when it comes to modeling, regardless if it's our modeling or any type of model. So once again, modeling is just one of many tools for decision makers. We get to focus on the science and the math and epidemiology. Decision makers, policymakers have to consider all other factors, and hopefully they use our tools and our models to inform them. But once again, there are other factors when it comes to policy that we don't consider, because that's not what we're focused on doing. Also, even with a minor change, it can have a significant increase or decrease. Dr. Shiba, our mathematician, always says, especially with Omicron, you have an exponential increase and a potential for an exponential decrease, assuming no major intervention. So that just speaks to the nature of such a highly infectious disease. Ideally, we like to utilize leading indicators, and some of the leading indicators you'll see on the next couple slides. And unfortunately, the ones that get the most attention are the lagging indicators, the hospitalizations, the ICU, the fatalities. Let me pause and see if I have any. For everybody in attendance, please keep the Q&As coming. When I get to a natural pausing point, we'll definitely address them, or we'll definitely address them at the end. So Susan, thank you for your question. We'll definitely get to them, get to your question and others before we close out this afternoon. Thank you. I apologize, I'm on my phone. I lost Wi-Fi at home, so I'm on my phone, so I don't have multiple screens, so apologies for that. Let me see if there's anybody in the chat. Okay. So for HiPAM specifically, for little history, there was no organic modeling capability at the start of the pandemic in early 2020. And, Dr. Fan just reached out to the community and brought together like-minded individuals who just wanted to originally just talk story and just to put our minds together to figure out what's going on from a modeling perspective, because modeling has value for decision makers. And specifically, we quickly understood how unique Hawaii is compared to the rest of the country, because at that point in time, a lot of the models were not Hawaii specific. And when they did try to make it Hawaii specific, there were a lot of gaps because of the type of modeling that they did, or they just didn't have Hawaii specific data. So our focus for our model to this day continues to be Hawaii specific, driven by what's publicly available Hawaii data from our partners across the state. And we look at multiple types of data: cluster data, risk of infection, demographic data, or when we can get that, and so on. That was that third bullet point. Finally, I spoke a little bit about lagging indicators. Unfortunately, by the time we see increases in those lagging indicators, oftentimes any policy or a lot of mitigation is a little too late, because just like with a tsunami, if you try to build something when the wave's upon us, it's not going to have much efficacy. So that's really where we tie in the early messaging communication for our modeling. And finally, our models are meant to be defeated. When we put out a huge increase in numbers of cases or hospitalizations, that is meant to show what could happen or what might happen if no action is taken, really from the human behavior aspect. So with all that, next slide, please, Rukia. So this is not meant to be all encompassing once again, but these are meant to hit the major high points of what things impact all modeling, not just ours. So testing capacity, isolation quarantine capacity, the ability to have fast turnaround for test results, infectivity of the virus, all of those things, in addition to the ones below, but specifically those are the ones that people gravitate towards, have impacts on daily case counts, on our percent positivity, and the speed with which COVID, in this case, Omicron, spreads. I'm not going to go too much in the weeds in the mechanics of testing capacity, but I think it's obvious when you shut down one or two major drive-through sites, then that's going to impact how many cases get reported, because if people lose the capacity to get tested, then you're artificially reducing the future case counts. So once again, that's where we have to keep a pulse on operational and real-time constraints, because that does have an impact on what we see in the daily case counts and the positivity. And then we have to make some assumptions on the true spread, because that's going to impact assumptions for hospitalizations, et cetera. And policies obviously impact human behavior. And what may oftentimes be lost is timely, accurate and specific data. And what we mean by that is, how quickly do we get the daily case counts? Is there a 24 to 36 hour lag on any given day? How accurate is it? Sometimes there are case counts which account for a backlog in cases, and that really impacts our ability to truly understand the time series when those cases truly occurred, because then it's just averaged out, and then that really hampers our ability to really understand the timeline of how COVID manifested throughout our population across space and time. And finally, specific data, understanding the uniqueness of Hawaii, our demographics, our kupuna. We have more kupuna than some other states. We have other ethnicities which have other risk factors, and to comorbidities which increase the risk of COVID and other types of respiratory diseases. All of those things, if we have that, can increase our ability to look at, let's just say, future hospitalizations. Length of stay is another one, and for the hospitalizations that we have, how many of them are vaccinated or unvaccinated, or there because they have a comorbidity and they're hospitalized because of the comorbidity and they happen to test positive for COVID. So all of these things can be lumped up into timely, accurate, specific data. Finally, human behavior, mask wearing, gatherings, just to name the top two easy, low-hanging fruit. Impacts are too difficult, but definitely numerous to really identify. Human behavior is the biggest variable we just cannot account for in our model, which is why we place so much of our emphasis on education and just messaging, because once again, our models are meant to be defeated. We don't want to see a huge increase, and hopefully that's why we interact with the community and we can decrease that. And finally, all those variables and the specific impacts lead to an overall impact to the modeling, and can either increase or decrease the accuracy of when we might project peaking of case counts, the duration, if we're going to plateau, how long that plateau is. And then, it makes sense that once that happens, then that impacts the accuracy of our hospitalizations, ICUs, and fatality estimates, because everything is based off the leading indicator of case counts. So let me pause and see. So Susan, two questions from you. Let me address them. And Dr. Fan and Dr. Shiba, if you have any comments as well, please feel free to jump in. First question for those who are unable to look at the Q&A chat. First question from Susan: what is your confidence level using DOH data? Many have noticed that DOH and HiPAM numbers do not match. Do you have any ideas about that? So, we are grateful for the data that is shared by DOH. We don't have visibility to the data that DOH gathers. We assume that it's the best the state has. We did notice the lag between DOH, HiPAM, and it's not. And so when you look at the numbers, it doesn't match up. But it's because a lag exists between when DOH reports the data versus HiPAM. So that's why it doesn't match. It's not because they're not correct. There is a lag. At least that's our best guess. And second question from Susan: based on what we see right now, are there interventions or mitigation strategies that, if you're in charge, could help Hawaii? Susan, great question. We're not in charge, and thankfully we're not. Once again, we're scientists, mathematicians, epidemiologists. We focus on what we're good at, and what we know we're not as well read on and studied on is other economic impacts. Other types of social, economic variables that policymakers have to consider. And so, it's difficult for us to really suggest anything, because it would be a little too biased towards just the pure science perspective. And to be fair to all the social determinants of health, we need to account for all other variables that impact our daily life. But thank you for those questions. Marilyn, what impact does the lack of data from individual schools have on the overall infection rate? So really good question. I can't answer that directly, but what I can infer is, it probably presents it definitely presents an undercount on the true number of cases. And we do know that there is a disparity, or there's a difference in terms of risk based on age. And obviously there are other health impacts, mental health impacts that have secondary and tertiary impacts on our keikis. So, having the best available data is important, and definitely not having that will impact policymakers' ability and our ability to truly understand the spread and the speed with which the infection is kind of going through our population. So thank you for your questions. Please keep them coming. Next slide, Rukia. So just to end on this slide, and before I hand it off to, before we start to go to our weekly report and where Dr. Shiba is gonna jump in a little bit. So some examples of timely, accurate, specific data. I touched upon them earlier, but I think it's important enough to rehash. So daily case counts, accounting for testing and reporting lags. An example of that, what is the breakdown by vaccination status? I think given the clinical and epi information that's out here, it is clear that, if you're fully vaccinated, the impact to your health is decreased in terms of you'll still be symptomatic, but you definitely won't, you have a decreased risk if you're vaccinated with 2 doses, and even more so with 3 doses of an mRNA vaccine to prevent yourself from going to the hospital, assuming that you don't have any comorbidity. So having that understanding of the breakdown of vaccination status, not just for daily case counts, but for hospitalizations as well, is important. I also wanted to point out limitations to mortality data. So when, let's just say we see 5 new deaths reported today, I think it's important for the public to understand that's not, it's not to say that 5 deaths, there were 5 people who died today of COVID. It's just when those death reports were released. So that really makes it difficult to, for us to kind of marry the data of, okay, yes, 5 deaths reported today, but when do those deaths truly occur? And it's really hard for us to link that with the hospitalization and case count. So, with that specific data point, I wanted that to be known in terms of the limitations of looking at mortality data. Finally, huge focus right now on hospitalizations. We're over 340, I want to say today. I apologize for not having the accurate number, but length of stay, vaccination status, comorbidities, and gender are just 4 easily understood variables that can impact modeling assumptions, but also just how we communicate risk of hospitalizations and the status of hospitalizations, not just in Hawaii, but across the country and across the world. Early reports suggest that length of stay is shortened for vaccinated individuals for Omicron compared to unvaccinated. But even taking a step back, comparing Omicron length of stay versus Delta, early reports also indicate that it is shorter regardless of vaccination status for Omicron versus the Delta variant, which suggests that just overarching less severe disease in Omicron versus Delta. Not to say that you shouldn't get vaccinated. Once again, we're just saying that that is something of note when you're comparing length of stay versus Delta, Omicron, and then vaccination status versus non-vaccinated and vaccinated. And then comorbidities, from day one, and it continues to be the case today, from an epi and a clinical standpoint, if you have 1 or more comorbidities, you're just, regardless of your vaccination status, you're still at greater risk than the baseline healthy average age individual for reinfection or infection as a breakthrough case of COVID, and potential increased risk for hospitalization purely because of your comorbidity or comorbidities. And then also, some epi studies have shown that males are at greater risk of COVID than females. Not sure if that holds water in Hawaii, but once again, that's what some national data suggests. So these are just some easy examples of timely, accurate, specific data. And if you pay attention to our reports or just the media, it's obvious which data points we have and which data points we don't. And hopefully, from a hospitalization standpoint, if we can better understand the relationship of comorbidities, length of stay, comorbidities and vaccine status to length and age, I apologize for not having age on there, to length of stay, then we'll better be able to connect what's going on in terms of the case counts and hospital admittance, and then estimate, the length of stay and the point in time if and when we peak, and duration that we will peak for hospitalizations. Because without that, given what we see from an epi level, it's just too difficult for us to truly say at what point and for how long we'll peak. Even though we try, but there's a lot of missing data gaps that could truly improve our modeling. Next slide. So once again, I think I touched upon a lot of this, but it bears hearing once again, or at least seeing. So, and this will be on our Instagram, and we will upload this onto our website. But Omicron is much more infectious than the Delta variant. Early studies indicate 2 to 4 times increased infectivity. Results, however, it does result in less hospitalizations, with a caveat, once again, like I touched upon previously. Age, comorbidity or comorbidities and other health risks can impact that very simple relationship between Omicron and fewer and less severe disease. We do see that 2 doses of an mRNA vaccine are still effective against severe illness and hospitalizations. Sorry for the typo. However, you do have an increased probability of breakthrough case and developing symptoms due to an Omicron infection versus Delta if you have 2 doses of an mRNA vaccine or 1 dose of a J&J. The question we get a lot is, so how protective is a booster? Getting a booster, so 3 doses of an mRNA vaccine or 1 J&J and 1 mRNA vaccine. It does increase protection against infection and furthermore, additional protection against severe hospitalizations. But the question is, what is that difference between 2 to 3 doses? I think we don't have enough definitive data yet. And the other question is, that we've talked about a few times in our previous community meetings, is global vaccine equity. Even though we have boosters available here, and we should make use of it, the overarching global health perspective is, Omicron started in South Africa, originated from South Africa because their vaccination rates were lower. They were still trying to get access to the same amount of vaccines that a lot of first world countries have, and we will continue to see that possibility until we establish greater global vaccine equity. So that's just a plug from my global health perspective that I wanted to put in. Oh, sorry, Rukia, I may think I touched something on my phone. Rukia, is this slide up? It might just be my lag. Okay, perfect. Next slide, please. Yep, I can see the slides, Rukia. So we're currently on what we know so far, and if we can advance to the next slide. Monique, if you can see the next slide, please. Oh, sorry. Let me see. Okay. Monique, can you see your slide up?
Yeah,
or are you seeing it?
yeah.
Okay.
Yeah.
If you okay, perfect.
Yeah.
Can we go back 1 slide, Rukia, please? I apologize. I do want to go over the opening slide. 1 more slide, please, Rukia. The lag may have been on my end. Yeah, perfect. That slide. So before I hand it off to my esteemed colleague, Dr. Shiba, so the summary, I'm not going to read a lot of it. The bottom line is stuff that I just previously said, we have really, with the emphasis on hospitalizations due to our understanding of Omicron, that continues to be our focus, though. We will acknowledge at this point, there's a lot of other secondary, third order effects. For example, impacts to EMS and emergency services, teachers, that Omicron is causing disruption on, in addition to the increase in hospitalizations. We have data limitations. We do use data nationally, but it's worth us noting that we have very limited local data to inform our estimates. And the assumptions, can be found in prior updates. And then, in the green, positivity continues to trend upwards for all counties. And then based on the positivity, Maui is currently surging the most rapidly. And with that, Dr. Shiba, go ahead, please.
All right. Hi, good afternoon, everybody. So I'm going to talk a little bit about the forecasting, but I'll say a few things before. You can just maybe go to the next slide, Rukia. Okay, so here I'll just explain what we see here. But first, I'd like to make a few comments. So first, about the data, it is easy to think that here things are not done properly, but data collection issue for the pandemic has been really a worldwide issue. We entered the pandemic with no protocol through the word on how to collect, nor there was clear guidance from people doing the modeling about what are the key data to collect. So nobody was ready to enter that pandemic from any side, right? Epidemiological modeling is fairly recent. It started, the tools that we are using now were developed before in the early 20th century, the last pandemic. So that means it was very theoretical, and suddenly sort of within like the blink of an eye, we were thrown into the reality and started to understand what factor impact the model and then what we need to take into account. And so it is always, when you go from the theory to the practice, there is a big gap, and that's what we're experiencing. And because we're in the midst of the pandemic tsunami, we are still figuring a lot out, but there are major progress happening. And I think the year when the pandemic will evolve to an endemic, the year after that are going to be a major accelerator for epidemiological pandemic. So again, we're all in the same boat. It's not just Hawaii struggling to figure out the bridge and the link between the data, the modeling. It's really a major worldwide issue, and everybody is doing the best that they can. So what you see here, that's a spiral representation. There are different ways to represent them. People might not like, we're used to have representation in one way or the other, and then but this is the pandemic. So and what has been very important for Hawaii to look at is to really break down per county. The county have behaved very differently. They've been affected at different time in a different way by the pandemic. So it is really important to then look at mitigation measure per county, look at what is happening per county. Maui has a different ratio tourist versus residents, so it impacts the count and the spread in a very different way. Honolulu had more like people that were under restriction to get vaccinated, so it went into a higher vaccination rate more quickly than the other island, and therefore everything was sort of different. So this is what you see in those spiral is sort of the evolution of the pandemic, and different color are different county. And the idea here, whether like some people might like it, some people might not, but the idea to go into a spiral like that might help you to see things that you don't. If you have the typical Euclidean representation in a Cartesian frame, because here you might be able to see some seasonality. It is like in the, like if you see the COVID hospitalization on the left, you can see that it has tended to grow, at least for the first couple of years, between like in the early fall, that's where hospitalization went up. Of course, now we are growing, but that's the type of pattern that you wouldn't necessarily see that easily otherwise. But it does not bring more information. It's just a different visualization. If we can go to the next slide, please. Okay, so this shows just the evolution through the pandemic of the COVID death. And we can see that it has been evolving and it has been growing, and that's very unfortunate. So if we can go further. All right, so we're going to discuss Honolulu County, but before I go into the discussion to Honolulu County, I'd like to highlight a few things. It is with the Omicron, we have a very different situation than we had with Delta. Even the modeling is fairly different. So we had to really, and I'll take that opportunity to really shoot out for the students. I have a whole set of students, like 4 or 5 really loyal students that have been working on that for a year and a half and developing the model with me and working on weekends to do those updates. So really extremely fantastic job from the students that have worked on that. They've learned a lot. So Delta and Omicron is very different. So when we started seeing the rise of Omicron, we had to really completely modify the model to have 2 variant competing with each other, but not just 2 variant competing with each other with the transmissibility. We had fundamental structure of how they were acting on the population that were different. Like with the Omicron, the asymptomatic play a very different role. Well, they both play a very big role. I mean, the vaccinated. With the Omicron vaccinated, we saw much more breakthrough cases with the Omicron. We have more vaccinated people in the hospital with the Omicron, and there was no real clear way to anticipate that, but to look at what was happening in other countries. And those have different population, they have different demographics. So it was difficult to really start estimating what could happen in Hawaii, because we were using data coming from very different situations. So we can see, as Thomas did a really good job to try to explain the difference. Right now we have vaccinated people in the hospital, and the vaccinated people in the hospital, they might not stay as long, they might not go into the ICU. So all of that has to be taken into the model. And then again, we have still Delta hasn't been completely killed, at least at the beginning of December when we were looking at the data. And so we really had to compete that, both variant together. So again, it has been a very different modeling experience once we entered the Omicron first, because there was a lot of unknown with that variant. With Delta was a little clearer. It was transmitting faster, but then it was sending people to the hospital at about the same rate than we had before, and vaccinated people were avoiding to go to the hospital. That was mostly the primary difference that we had. But with the Omicron, we have much more subtlety coming into the picture. So if we can go to the next slide. All right, so this is a little bit comparison between Delta to Omicron for Honolulu. And you can see on the upper left, you have the orange is Omicron and the blue is Delta. And you can see those are on the left. I left the raw data cases because you can see the oscillations are major, and then it makes it really hard. And it makes it not very clear, are we going to, is it because the testing, or is it really the cases that are oscillating that widely? It is because the way the results are reported, that's very unclear. So usually we try to fit better the 7-day average, but I wanted to show that because those are the raw data that we have in order to work. But what you have to see here, there are 2 main things to observe, right? For Honolulu, you can see that the daily cases are shooting really much higher with the Omicron because it's much more transmissible. For Hawaii, we saw that with the best fit that we have, the best estimate through the model can do is that Omicron is about 2.5 times more transmissible than Delta, and you can really see that into the curve. However, for the hospitalization, you can see that they're basically in sync. So it's very clear that there are less people that are affected by, that are infected by Omicron that end up in the hospital and then the ICU. However, you have the positivity. Okay, that's the middle upper plot that we have, and that one is very important. The positivity is much, much higher with the Omicron and much more so with the outer island. And that's what we are watching. The reason is that positivity means more infected people, and then something that we can see maybe that does not translate into hospitalization, but it translates into depletion of the workforce. And that's a new issue that we didn't have before. Then the upper right that we have the plot, this is interesting because it says what happened with the Delta. This is just for the Delta between the positivity and then the cases. And then we saw that positivity started plateauing before the cases started to go down. So that's one of the indicators that we're going to be looking at in order to try to make the gap and infer that we might be going down. So if I can see the next slide. All right, so this is the forecasting for the daily cases. So you might believe that there is a mismatch between the daily cases and our fit, which typically is the green, which what we assume is the best fit. The reason is that it's unclear right now what is going on with the daily cases. They seem to be plateauing while the positivity has been going up. So the model is inferring that there are more daily cases than what we see. And we prefer to keep that inference from the model because we might be hitting maximal testing capacity. And in that case, it's not, the daily cases would not give a complete picture of what's the reality. So it's right now we're looking at maybe peaking a little later toward like the third week of January, and the value are still there. And those value, we are likely not going to reach them because again, we have testing max capability that might not let us find all those daily cases, but that's what the model is inferring. If we can go to the next one, because those are the hospitalization. And then here, the hospitalization, you can see that they're much more aligned with the fit, and that's what we take as a benchmark. And the hospitalization are projected right now to peak by the end of the month. So one caveat that we have in the model is that we have zero data about the number of reinfection. So we don't know if there is a big flux from people that get the Omicron that go back into the susceptibility pool. If it is the case, then the peak might happen a little later. But we are, from the data, I would say we are on track to go between 400 and 600 hospitalization in Honolulu for the peak. But again, that might change drastically. We don't know the demographic in the hospital, and we just have a crude number on the number of vaccinated. We don't exactly know the length that they are in the hospital, etc. So that's what we have here. Can we go to the next one, please? Rukia, if you can go to the next slide. All right, so the next one is a slide that shows a difference between the Omicron and the Delta, and in particular the fact, okay, this is the next slide. So we have, it shows just how the asymptomatic play a different role in different in the different phases of the pandemic. So the first phases is on the very left, with the blue, with sort of the blue loop. And every time you come back, it's then when we peak, when the loops start coming back down to sort of the, what we see, and the 0-0, it does not go back to 0-0. It goes back to what eventually we want to call, I think, the endemic equilibrium. But you can see that the asymptomatic are playing a very big role right now in the pandemic. Can we go to the next one? And that's one of the reasons is that we have a lot of people that are vaccinated and that are not showing symptoms. And for the Omicron, then we have a lot of, since it is milder, we don't see all the symptoms. So the next slide is going to be about Hawaii County. So I'll let you go to the next one so that we can, maybe because it's slow, you can go to the next one and the next after, whether hospitalization, or I will say. So for Hawaii County, they started putting mitigation. So we are on the lookout on how the mitigation on the gathering are going to play out. They have their positivity. It seems that it might be starting to kick in because positivity, positivity is sort of stabilizing in Hawaii or even going down a little bit right now. So we're going to see in terms of hospitalization, This is the daily cases. So we're still seeing a peak about the same time, slightly after Honolulu. The other islands are slightly after Honolulu, but you can see the peak, and you can see the lower the peak, the further out it is in time. And then if suddenly we start like flattening the curve, that means the peak is going to happen later and the descent is going to be less rapid. But we're going to preserve better the public health system, which is a desired outcome, right? So this is for the hospitalization. So we are sort of anticipating like being on track for above, like for around maybe 100, 150 hospitalization for Hawaii. Then if you continue, the other slide are mostly the same type of information for the county that I'll try to wrap up a little quicker so that we can answer some of the questions. There are some questions I see, or some comment in the chat. So I want to make sure people have an opportunity to do that. So what we have for the other island right now, we're really watching Maui. Maui has the largest positivity. And these are more slides. You can go into Maui, and the hospitalization is lower right now on Maui. But however, again, the positivity is the highest of the 4 counties. And even though like it seems that they're in good shape because their daily cases are under the blue curve, but the green fit is actually more stringent than the one for Hawaii County. So it is from our perspective, Maui is more a concern than would Hawaii County be as of now. Again, they also started some restriction on gathering as well as on Honolulu. So we're going to keep an eye on that. And for Kauai is difficult because we were able to model them only further out into the pandemic because their numbers were low, but we are still looking at a peak that can go possibly up to 500 cases on Kauai, which will be a lot and definitely depleting their workforce. And in terms of the hospitalization, we're looking at maybe going into the 50, and that's a concern. Their capacity is different, and there are like positivity is still going up on Kauai. So those are the factors that we are looking at. Prediction and forecasting is extremely delicate right now. It is very difficult to anticipate when we are curbing. There is a lot of discussion worldwide about whether the UK seems to be curbing, then some other countries in Europe seems to be following, but slower. The reason is that the imposed mitigation, like restriction that the UK did not necessarily have. So the UK went up much more, but they're decreasing faster. So there is always a trade-off, and we're going to see what is going on in what is going to happen in Hawaii, but that's what we have as of now. So maybe I looked at I will look at the question. So yes, we can do different mitigation strategy, and that's something that we could do. That's what the model is good for. We could try to put but it's unclear right now what type of mitigation strategy we will be looking at. We can just reduce base transmission. I think someone had a question about what is the base transmission. So base transmission is just how is the virus transmitting between 2 individuals, okay? So, and it's not necessarily, it does not necessarily take into account the interaction and everything between the individuals. So I can still talk, right? Yeah, okay. So yes, we could do slides that like assumes on some mitigation strategy. The cruise ship the cruise ships are very targeted event, and this is really hard. So that means you suddenly have an influx of cases. So we can put that into the model and see how it grows. And then why is Maui positivity rates the highest? That's a good question, and I'm not able to answer. I don't know why they are the highest. One of the reasons that we see is that they have more tourists. There've been more traveling. That's the only main difference the ratio tourist versus resident or traveling versus resident is higher, and that I don't know, it hasn't been established that tourists have been the major concern. So that it seems that there is a lot of community spreading on Maui, and I don't know why.
Thank you, Dr. Shiba. Definitely appreciate all the great information and a very easily understood breakdown. Well, one thing to get to Susan's point or question about the cruise ships, what makes it difficult for versus some of the planes, and we have a better understanding about travel from planes because we have a lot more historical data. Throughout the pandemic, we continue to see tourists come in, but we restricted the impacts from cruise ships. So it's hard to say.
Thomas, your connection is broken out, I think. I'm not sure if others can hear you, but
No, we cannot. Okay, so I'll take the opportunity to answer to Marilyn. She's asking if the model could have any possible prediction utility for Micronesia. Yes, the model can be transported to different islands. It's going to have to be tailored, and it will come with like a lot of question mark about the estimate, because indeed they went through a very severe lockdown. And so we don't have a good understanding on how it will affect, but because we have Pacific Islander here, it could give us some head up on how to estimate the parameters. So it could be used to transport into modeling Micronesia once they start reopening.
Sorry, I dropped off. I had poor connectivity, but sorry, Dr. Fan. Before, I just want to, we do have one of our co-chairs who lives on Maui. Tom, if you want to mention, you're definitely probably the foremost expert on Maui. So if you have any thoughts, I wanted to extend the invitation to you.
Can you hear me, Thomas?
Yep,
yes,
loud and clear.
Yeah. My thoughts are that, in the early days before Omicron, we saw from DOH that the transmission for residents was a bit different from tourists. Maybe the same now with the much higher levels of Omicron, right? So that might be what we're seeing.
Thanks, Tom. Sorry, Victoria. Go ahead, please.
no worries. Margot, Dr. Edwards, thank you so much for asking about the funding sources, and I'm happy to chat with maybe you separately, but just to let you know, we have approached HiPAM, DOH, at least almost a dozen different sources. We've asked hospitals, the university, we've asked the university for support.
And the university just came through with the funding support for the students.
Yes, that's which is tremendous, and that'll get us through at least the Omicron. But would love to chat with you if you're willing. Maybe we could have a separate conversation about that. I know your work was tremendously helpful early on in 2020. It seems like such a long time ago, and ARL is such a important research center at the university. So it would be great to find a way to collaborate. And also we put in a federal appropriations request through the university system as well.
Yeah, thank you, Margot and Victoria. This is huge. Once again, we're all doing this out of labor of love for our community and for our state. So, I know everybody looks out for our weekly report, and apologies it wasn't earlier this week, but I know the semester started for UH, and obviously students are our priority as well. Wanted to hit a question in the chat from Mr. George White. So, we unfortunately we can't speak to the operational and the behind the scenes reporting lag we once again we're independent to that. We utilize heavily the data, but the operations and the mechanisms behind the reporting and the delays and discrepancies, we don't have visibility on. So, great questions. Obviously, hopefully our slides kind of spoke to the importance of timely and accurate data. But those questions, unfortunately, we can't answer. But we are confident that they're continuing to improve upon that. And to definitely, to be fair to our colleagues in DocD and DOH, they've been working nonstop, since the beginning of the pandemic. So it's not easy for anybody. And I think compassion is huge, and we're all working as best we can. So understandably, we all strive for the best data, the most timely data. But there are, being in operations in the Army myself, there are oftentimes a lot of things that can impact delivery of data in a timely manner that oftentimes is not brought to light. So just wanted to put that out there, and thank you, thank you, Susan, and everybody, for your questions. Let me see if there's any others in the Q&A chat.
Thomas, I see in the audience participants, we do have some folks who may be able to answer the questions about HiEMA and DOH differences. I don't know, I don't mean to put any of them on the spot, but if they're willing, please let us know. We're happy to give you the permissions to talk.
Thanks for bringing that up, Victoria. Back on my phone.
To your point, George, the most recent one that you said about which version do we use, we try to use the most accurate version. Obviously, the later it is, the more likely it is to be cleaned, but the trade-off is timeliness. So, it's not easy. We'll just leave it at that.
But I think, ideally, this is where the intersection between academics and the constant desire for perfect data, you coincide, or that's the wrong word. You have to mesh with real world operational limitations. In a battle space or on the ground, you have the fog of war. There's a lot of data that you don't have, and you have to make the best with what you have. Continue to try to improve data communications and data gathering. So I understand we're 2 years in, but once again, at least from HiPAM's perspective, we can only influence what we have, and we have some flexibility with tinkering, like you said, with the timely data that we have. But beyond that, it's data that we have access to from the state. So and which we definitely want to utilize.
If I can say something that is very unique to epidemiological modeling, and that is really key to understand, is like, even if we get the perfect data, this is never going to be an oracle. We're never going to be able to be accurate to to 10 daily cases, even with ideal data. And the reason is that the dynamic is people driven. And this is the uncertainty of what people and what choices they're going to make is extremely large compared to the other impact of the data that's very dominant. That's the way that you affect the curve is by putting restriction measure, which means by changing people's behavior. And this is something that is extremely difficult to account. So the modeling has to be understood, and Thomas said that at some point. It is really something you won't defeat. It is not an oracle that is going to tell you, this is where we'll be. It is something that tells you, this is where we're heading. If you like it, then let's head there. If you don't, we have to make action. We have to take proper decision. This is what the modeling for epidemiological is. It's never going to be something that is accurate to the degree of we send a Mars rover on Mars, or we do something with mechanical system. That's a very, very different kind of model, and that's what we need to understand. Sorry, thank you.
Oh, thank you, Dr. Shiba, for that. I think we'll wrap it up. We're past the hour, and once again, thank you everybody for your attendance and participation. This is the biggest crowd we've had in some time, and hopefully, it's not just because we're surging due to Omicron. We do put out other information, that in terms of masks and other types of pharmaceuticals that have an impact on the overarching landscape of modeling and COVID. But if there's no other burning questions, yes, Susan, we have to accept plus and minuses, the positive benefits. There's no perfect situation. We're not in a lab growing a species or a virus. We have to account for constraints and limitations. But I really want to say thank you to Dr. Fan, Dr. Shiba for the constant work, and Tom for being another co-chair and a rock as we kind of might mitigate and kind of navigate through these waters. If you have questions, please feel free to email us or reach out on our Instagram page. We'll continue to improve how we communicate with the community at large. But thank you again for all your time, and until we have another community meeting, if we need to have another one sooner than 1 month, you'll get an invitation, and we'll prepare something. But thank you again for all your time. Please stay safe, and hope to see you on the other end. Take care, everybody. Mahalo.